Welcome to the COVID-19 What Pharmacists Know Now series. Today's presentation is on COVID-19 and cancer patients. My name is Sally Waignein. I'm the Provincial Pharmacy Education Coordinator and Residency Coordinator at BC Cancer Provincial Pharmacy and Clinical Instructor at the UBC Faculty of Pharmaceutical Sciences. This presentation is brought to you by the Canadian Society of Hospital Pharmacists BC branch. As you have seen in the other What's Pharmacists Know Now presentations, research in COVID-19 is evolving by the day as the pandemic continues to unfold. Evidence surrounding COVID-19 in cancer patients remains scarce, and the information presented today is based on the best available evidence as of April 16, 2020. This presentation aims to address the four following questions. Are cancer patients at higher risk for COVID-19 infection? Do cancer patients face worse outcomes with COVID-19 infection? Should anti-cancer therapy be delayed to reduce the risk of immunosuppression? And what other mitigation strategies can be adopted? So our first question is, are cancer patients at higher risk for COVID-19 infection? Well, we know that cancer patients are at an inherently higher risk for infections in general due to their immunosuppressive state. This could be from the cancer itself or from their anti-cancer treatments, such as chemotherapy, radiation therapy, surgery, and stem cell transplantation. Stem cell transplantation carries significantly higher degree and prolonged duration of immunosuppression compared to typical chemotherapy regimens. Now, whether immune checkpoint inhibitors affect a patient's risk of COVID-19 infection is unclear. However, they often cause serious immune-related adverse events such as pneumonitis, which requires high dose and long-term corticosteroids, which can exert significant immunosuppressive effects. Cancer patients also require frequent outpatient visits for assessments and treatments, or hospital admissions for treatment-related complications, further increasing the risk for infections. Other challenges unique to the cancer population include the risk of COVID-19 infection on an already compromised pulmonary system, such as in lung cancer patients or those with lung metastases. In these patients, the diagnosis of COVID-19 can be challenging, given that the cancer itself can often present with similar symptoms and imaging findings as with COVID-19. So what is the literature telling us about the incidence of COVID-19 in cancer patients? In a recent meta-analysis of 11 retrospective studies that was published on April 6 by Desai and colleagues in JCO Global Oncology, the overall pooled prevalence of cancer in COVID-19 patients was found to be 2%. This is further informed by one of the largest dataset published to date by Liang and colleagues on February 14th in Lancet Oncology. This paper reported data collected by the National Clinical Research Center for Respiratory Disease in China and included confirmed COVID-19 cases across 31 provincial regions in China up until January 31st. Of the 1,590 confirmed cases of COVID-19, 18 of these were in cancer patients. This constituted 1% incidence in cancer patients, which the authors noted were higher than the 0.29% incidence of cancer reported in the general Chinese population. In the 18 cancer patients, the most frequent cancer type was lung cancer. Results showed that cancer patients had numerically higher risk of severe events, defined as a composite of ICU admission, invasive ventilation, or death, of 39% versus 8% in patients without cancer. In fact, cancer represented the highest risk for severe events. Of the 18 cancer patients, 4 patients who received chemotherapy or surgery within the past month had higher risk of severe events with an odds ratio of 5.34, even after adjusting for age, smoking history, and comorbidities. Cancer patients also deteriorated more rapidly than non-cancer patients, with a median time to severe event of 13 days compared to 43 days. However, data presented in this study should be viewed with caution, given the small sample size of only 18 cancer patients, and that these data were collected relatively early on in the course of the COVID-19 pandemic. These are also solely based in the Chinese population and it remains unclear whether these findings can be generalized to the North American cancer population. The second question we wanted to address was, do cancer patients face worse outcomes with COVID-19 infection? Well, we already had a glimpse of this in the Liang study just discussed. But in a more recent and most comprehensive dataset published to date, the World Health Organization and China Joint Mission on Coronavirus Disease reported on all confirmed COVID-19 cases in China up until February 20th. They found a crude fatality ratio, defined as the proportion of individuals diagnosed with a disease who die from the disease, of 7.6% in cancer patients. This was twice the rate of fatality as the overall COVID-19 population of 3.8%. This report established a strong association between the presence of comorbid conditions and mortality from COVID-19 infection. Patients with a history of cardiovascular disease, diabetes, hypertension, and chronic respiratory disease were also at significantly higher risk of dying. These results were confirmed by data from Italy, showing that cancer is amongst the risk factors of comorbid conditions that can increase the risk of death with COVID-19. In fact, the higher the number of comorbidities a patient has, the higher the risk of mortality. The last journal article I'll discuss today is a pre-proof journal published on the Annals of Oncology on March 23rd by Zhang and colleagues. This was a retrospective cohort study in 3 hospitals in Wuhan, China, conducted between January 13th and February 26th. 28 cancer patients were identified with confirmed COVID-19 infection, of which the median age was 65. Cancer types varied, with the most common being lung cancer, constituting 25% of the study population. 36% of patients had metastatic or stage 4 disease. Now, interestingly, only 21% of the patients received active cancer treatment within the last 14 days of COVID-19 diagnosis. So potentially, this could have been a rather healthy cancer population, likely comprising cancer survivors who did not require active treatment. In terms of clinical presentation, these patients seemed to have presented as per typical COVID-19 presentation of fever, dry cough, and dyspnea. The rate of severe clinical events defined as a composite of ICU admission, mechanical ventilation, or death was 53.6%, which was markedly higher than the 29% reported in Liang's study. However, similar to the Liang study, the recent use of anti-cancer treatment was significantly associated with severe clinical events with a hazard ratio of 4.1, even after adjusting for age and gender. Now, other studies have also showed that lung cancer patients in particular were more likely to present with patchy consolidation on CT earlier on in the course of their disease compared to the general COVID-19 infected population. And indeed, patchy consolidation on CT on admission was another significant risk factor for severe clinical event with a hazard ratio of 5.4. Overall, the mortality rate among the 28 cancer patients in this study were about 29%, with a median time from admission to death of 16 days. Again, results from this study should be interpreted with caution, given the small retrospective nature of the study that involved a heterogeneous group of cancer patients with very different tumor types and stage. The third question we wanted to address was, should anti-cancer therapy be delayed during the COVID-19 pandemic? Well, this requires careful consideration of the risk versus benefit ratio at both the patient and systems level. At the patient level, we may want to consider whether delaying treatment can increase the risk of the cancer coming back or progressing. This risk depends on the type of cancer and the stage of the cancer, and there's certainly data in specific cancer subtypes to guide decision-making. There's also COVID-19 specific guidance available for breast cancer, hematologic malignancies, hepatocellular carcinoma, and surgical oncology. But where the evidence is less definitive, multidisciplinary review may be needed on a case-by-case basis. What about patient factors like older age or comorbid conditions that we spoke about earlier? What is the treatment intent? Are we striving to cure the patient of the cancer, or is this treatment for palliation only? What is the magnitude of absolute benefit compared to the risk of infection? What is the risk of serious complications inherent to the treatment itself, such as febrile neutropenia or intractable nausea and vomiting that may require hospital admission? What are the patient's wishes? At the systems level, we must be cognizant that healthcare resources are finite and must consider the local capacity to manage the surge of sick patients. If the pandemic limits access to these resources, consideration should be made to prioritize patients for consultations, assessments, and treatment. This may require prioritizing treatment to acutely preserve life or limb, such as with oncologic emergencies like cord compressions, life-threatening bleeding, or respiratory obstruction. To prioritize treatment for which there is a high likelihood of cure, and to those with significant magnitude of absolute survival benefit. And to prioritize treatment that can prolong survival while improving patients' functional status and quality of life. And the list goes on. But in addition to considering whether active treatment should be delayed, there are a number of other mitigation strategies that can be implemented. The American Society of Clinical Oncology and European Society of Medical Oncology, among other international groups, have put out guidance statements on how to manage cancer care during this current pandemic. I think this pandemic has really inspired the healthcare community to look at creative solutions on how to safely and effectively deliver cancer care in a resource-limited environment. And I think these solutions will have lasting effects on healthcare delivery overall, even after the pandemic is over. I want to summarize the BC perspective here, which is taken from the BC Cancer Provincial Cancer Clinical Management Guidelines in Pandemic Situation COVID-19 document published on April 14th. Many of these mitigation strategies discussed here align with international guidance statements. The BC Cancer Guidelines states that the goal is to provide cancer services to the largest possible number of patients who are likely to benefit in a safe manner that minimizes risk of exposure to other patients, healthcare providers, and flattens the curve of incident infections. In terms of assessment or treatment strategies, consider deferring follow-up appointments if there are no negative impact on clinical outcomes, or if necessary, conduct via telehealth. To use regimens with longer intervals, such as giving an LHRH agonist every 3 to 4 months versus every month, or giving checkpoint inhibitors every 4 or 6 weeks versus every 2 or 3 weeks. Select protocols with shorter duration, hold maintenance chemotherapy, implement treatment breaks for long-term treatment for those who have had a good response so far. Switching from IV to PO where possible, deferring supportive care treatments like zoledronic acid, or encouraging use of granulocyte colony stimulating factor or GCSF in the primary prevention setting to reduce the risk of neutropenic sepsis. In terms of pharmacy considerations, perhaps provide more refill prescriptions at a time or mailing medications directly to the patient's home to limit travel to the cancer center and to provide patient counseling through telehealth. Lastly, considerations at the organizational level include setting policies to screen patients, staff, and healthcare providers for COVID-19 symptoms prior to entry, making every effort to ensure availability of personal protective equipment, conducting meetings virtually, and restricting staff business travels, among other strategies. In conclusion, I hope that we were able to adequately address the 4 questions we set out at today's presentation. To summarize, the current evidence remains inconclusive, but limited evidence suggests that cancer patients may be at higher risk for COVID-19 infection. And for those patients with COVID-19 infections, cancer patients are associated with worse outcomes. And this includes a higher rate of ICU admission, invasive ventilation or death, and more rapid clinical deterioration. Cancer patients may also be at higher risk if they have other existing comorbidities like cardiovascular disease, hypertension, diabetes, and respiratory conditions. Whether anti-cancer therapy should be delayed to reduce the risk of COVID-19 infection requires careful consideration of the risk versus benefit. But many other mitigation strategies can be adopted at this time. and these may have lasting effects on how cancer care is delivered beyond the pandemic. Thank you for listening, and remember to practice good hand hygiene, social distancing, and best wishes for staying safe.